Welcome to Chapter 2, Health Policy, Cost, Quality, and Access. The key components to Chapter 2, Health Policy, is federalism, layered government, healthcare's iron triangle, costs, so sources of money and how it's spent, the quality of care, and access, the 5 A's. The iterative nature of policy, the ACA, and policy formation network. Federal policy making is important because of its uniformity across the nation and its impact on the healthcare system. But the states have an enormous amount of authority in their role in crafting healthcare policy. The 10th Amendment to the U.S. Constitution is what plays an integral role. This clause, often referred to as the Police Power Clause, reserves to the states those powers not expressly transferred to the federal government in the Constitution. Specifically, this means the states have the power to protect the public health and safety of their citizens through licensure and regulatory mechanisms controlling healthcare providers and organizations. Interestingly, especially in these current times, is that states can mandate certain individual behavior, such as compulsory vaccinations for public school students. Consequently, both state and federal governments make policy that affects healthcare providers and systems in their delivery of healthcare services. The state has the power to license providers and discipline them for professional misconduct. They also have the power to regulate the size and location of hospitals and other types of organizations. In some instances, states have concurrent authority with the federal government, for example, as it relates to Medicaid. With Medicaid, the federal government sets the broad parameters and funds up to 75% of the program, but the states can make determinations regarding provider fee levels and beneficiary eligibility. In addition to the provisions in the Constitution other than the 10th Amendment, such as the Interstate Commerce Clause, which permits the federal government to control some aspects of healthcare delivery. There are 3 fundamental concepts surrounding healthcare that relate to health policy: cost, quality, and access, the iron triangle. The government cannot take a policy action on one side of the triangle without affecting at least one of the other 2. For example, if a state were to expand Medicaid to give more people access to care, federal and state costs would increase. And if they reduce their Medicaid expenditures, fewer people would have access to care. So when Medicare refuses to pay hospitals for the costs that are associated with avoidable readmissions, it is both reducing costs and improving the quality of care by incentivizing hospitals to better care for the patient to avoid the readmission. So individual organizations can and do tinker in the iron triangle arena. It's really our focus of this course is to the public policy formation and how each of the 3 sides of the triangle motivate and are driven by public policy outcomes. As we start to begin our discussion on national health expenditures, it's important to understand the components that make up our total expenditures. And those are comprised of Medicare, Medicaid, Children's Health Insurance Program or CHIP, commercial insurance, personal or self-pay expenditures, and then other government-sponsored programs. For example, U.S. Public Health Service, Indian Health Services, military, VA. To define some terms that relates to national health expenditures, we want to define CMS. CMS, the acronym for Centers for Medicare and Medicaid Services. It is the federal government agency that administers the Medicare program and the federal portion of the Medicaid and CHIP programs. CMS is part of the U.S. Department of Health and Human Services, and even though the centers portion of the name is plural, the acronym CMS is singular. The administrative rule is what is issued from CMS to govern payment or non-payment for a particular procedure. And then gross domestic product, or GDP, is the monetary value of all finished goods and services that is produced in the country by individuals and companies collectively for a specified period of time, usually a year. So, for example, in 2016, the GDP for the United States was 18.757 trillion, and by comparison, the GDP for the second largest economy in the world, China, was 11.2 trillion. And then our per capita expenditures, that is the total amount that is spent on healthcare. That is the national health expenditures, NHE, divided by the population. Now in this diagram, you can see that public and private insurance provide the largest share of healthcare spending at 74% of the total. And what's even more interesting, as you see the breakout of that diagram to the right, you can see that Medicare and Medicaid account for more than a third of that spending. And why is that significant? Well, hospitals receive about 87 cents to the dollar in terms of the cost. And according to the American Hospital Association, and Medicaid reimburses about 90 cents for every dollar actually incurred as cost for the hospital. So when that makes up more than a third, you can see that in 2017, hospitals were underpaid by Medicare by $76.8 billion and $22.9 billion shortfall from Medicaid. In 2019, Medicare underpaid hospitals by $56.8 billion relative to their costs. And so if it costs a hospital $1 to provide care, Medicare is reimbursing 87 cents. So, and in Medicaid, they shortchanged hospitals by $19 billion. Combine that with increasing bad debt and an increasing amount of self-pay, which turns into or underinsured. You can see how difficult it is for hospitals to stay open. It accounts, when we look at our aging population, the amount of healthcare spending that is consumed by Medicare and Medicaid programs and the populations that are involved in those programs, the question becomes, are these social programs economically sustainable? What takes place? Do we have to increase tax? And to what extent is the American populace going to tolerate that? And what impact is it going to have on covered benefits and other healthcare decision making? Again, as we see the population continue to age, there are 10,000 baby boomers that retire every day, it's reported. And the medical complications that accompany people as they age, so you have more people entering into Medicare and more people that are in that age bracket that require or consume healthcare resources, you can expect to see these costs continue to climb. As mentioned earlier, the ACA that was originally proposed aimed at building on private insurance structures and an expansion of public programs such as Medicaid. So on the private health insurance side, the act required companies employing more than 50 people to provide health insurance for their employees. In addition, it required every individual to purchase health insurance if they were not otherwise covered by a plan. So importantly, the act provided subsidies to purchase health insurance to everyone whose income was between 100% and 400% of the federal poverty level, or FPL. When we look at how much we spent as a nation on healthcare in 2017, which was about $3.2 trillion, which made up about 20% of our GDP, which is about $10,000 a person, it is important to know where those dollars were spent. And this graph gives an illustration of that. You can see 32% to hospital care, 20% to physician and clinical services, and you can see the breakout of the remaining percentages. So as we look at cost and how it is spent, we may ask the question, has it always been this way? In other words, if healthcare industry groups were successful in either defeating healthcare reform or shaping it so it is more amenable to their respective interests, would the spending pattern for services provided by the three largest groups, would it have changed over time? And here this graph shows the answer to that partially from 1975 through 2015. And you can see that the physician portion of the healthcare dollar has been remarkably consistent over the years, while spending on prescription drugs has increased, which displaces, in part, some of the spending on hospital care. Hospital expenditures have declined from 38.4% of NHE in 75 to 32.3% in 2015, which is a drop of approximately 16%. Some of this shift is a product of improved technology, and there are also better pharmaceuticals that can help prevent hospitalization. Also, many invasive surgeries have moved out of the hospital inpatient setting to outpatient surgical centers. And this is part of a significant change in the healthcare system that we'll talk about next week. So hospital physicians and clinics and prescription drugs account for approximately 62% of the national health expenditure. And these three groups have consistently accounted for roughly that same percentage, between 60 and 63% for more than 40 years. So cost represents only one side of the iron triangle, but it is always at the heart of any healthcare debate. Does the government spend too much to provide care to those who cannot afford it? Does it spend too little? Should the private market play a greater role in paying for care? If so, how would that work? How do those who cannot afford the price of healthcare pay for it? And I would add, what has been the cultural changes over time in terms of faith in the community and society, the faith-based entities? Where did the church and charity care, as they provided these services to those who couldn't afford it, and the government has seemingly superseded the church in that regard, and what impact does that have? As it relates to quality, we're going to talk a lot about how the United States is compared to other industrialized countries around the globe in subsequent chapters, so I'm not going to get into it too heavy here, other than to say that there are differing opinions between what is reported in the performance rankings and what criteria goes into these performance rankings. The United States overall is a destination country for healthcare. So people come from all over the world to have healthcare, their healthcare services in the United States. So there is a real disconnect between the way some of these reports are presented that rank the United States, close to last in all performance ranking categories, and the reality of what's taking place. So we're going to discuss that in subsequent chapters. As it relates to quality, I will say this. As it relates to quality, high reliability organizations hate to get it wrong. It's specifically as it relates to safety. Safety is a dynamic non-event, meaning we work hard to make nothing happen. So the key takeaway from that is that safety in the hospital should be a core value versus just being a listed priority. It's about consistent, predictable behavior, and it takes time to develop. Consistency drives culture. If you were a healthcare leader and you had one of your loved ones coming to your facility for care, what would you want to know? It would probably be something like this in order. Don't harm me, heal me, be nice to me. I won't spend a whole lot of time on this graph other than to say there's a lot to debunk here. There'll be some journal articles and some other research to share with you in the weeks ahead. The 5 A's of access include availability, accessibility, and adequacy. Availability, reasonably available when needed. Accessibility, provider is in a physically accessible location. And adequacy, provider training and experience matched to patient needs. Affordability, can the patient afford the provider's fee? Acceptability, is there a language barrier? Is there a cultural fit? Regarding the iterative nature of public policy, it is never final. Policy is never final. Whatever prompted policymakers to act on healthcare in the first place may or may not be what causes them to revisit the initial policy in the future. The legislative branch passes legislation that becomes law when signed by the president. And administrative agencies implement the intent of the law through regulation. The business of adopting rules and regulations does have a process all of its own that is governed by the Administrative Procedure Act of 1946. This law requires an agency to publish proposed rules or regulations in the Federal Register and allow time for comment. Special interest groups play a significant role in the legislative process. Many consider the term special interest group to be pejorative and decry the group's influence on the legislative process. There's no doubt that there's some truth to this perspective, particularly as it relates to the campaign contributions that take place. That aside, consider that nearly everyone in the healthcare community is a member of one or more such groups. Physicians typically are members of the American Medical Association. An administrator may be part of the American Hospital Association. Pharmaceutical companies have Pharmaceutical Research and Manufacturers of America. Nurses belong to the American Nurses Association. Physician practice administrators belong to Medical Group Management Association, and so on and so on. All of these groups engage in the legislative process. In regards to legislators, they need information from these special interest groups as they are typically the experts on their particular areas of interest. They also need donors and campaign contributions, and special interest groups are ready to step up to that challenge. And then also, they also need creative interpretation of the regulations that they do work on to see how that is going to impact a particular area that a special interest group may have specific expertise or constituents that may assist with that feedback. And the same holds true for administrative agencies. So the relationships between legislators and administrative agencies are important as well. Those agencies rely on Congress for appropriations to continue their work. And then likewise, legislators rely on agencies for information, often for help with individual constituent matters and sometimes for enforcing the rule in a particular way. It's a symbiotic relationship as the agencies also rely on legislators. The policy formation figure here illustrates how special interest groups want to influence regulators' views, and legislators may seek to influence how the agency interprets the legislation that it's implementing. Because administrative agencies depend on legislators for funding and authority, the legislator is likely to get a friendly ear from the agency. And it's through this ongoing exchange of information and influence that policy is initiated, implemented, criticized, and changed again, reinforcing the iterative nature of both the outcome, no policy is ever final, and the process. So in conclusion, for Chapter 2, there are ebbs and flows in the sea of change with respect to government involvement in our healthcare system. Over time, despite occasional retrenchments towards less governmental intervention, the arc of history suggests an ever-increasing governmental role to make healthcare coverage more equitable and thus the delivery of healthcare services more universal. In the wake of the ACA, the movement in favor of reducing the government's role has gained strength. The next round of policymaking in this arena could well see a reduction in the scope of government intervention and a renewed focus on free market forces to drive a greater portion of health insurance and health service markets. But because of this ebb and flow and because this policy process is never complete, it's important that healthcare administrators understand the process so they can knowledgeably observe and participate in it. The policy decisions made at the federal and state levels have far-reaching implications for healthcare organizations. And those policy decisions are part of the milieu in which the healthcare administrator functions professionally. Failure to understand the importance of policy decisions and how they continually evolve can have a disastrous consequence.